انا دايما بستمتع بمحتوى دكتور تريز وبطمن كده ان احنا ماشيين كويس. انا النهارده هتكلم على intermediate uveitis، واهم حاجه في intermediate uveitis ان هي it is under diagnosed. الفكره كلها انه محدش بيدور عليه فمحدش بيشخصه. وده بيوافق الكلمه بتاع دكتور تريز ان هو anterior uveitis is becoming less common، لان حالات كتير جدا من اللي بتجيلنا كanterior uveitis احنا بنكتشف بعد كده intermediate uveitis. I'm going to start with the very first case with a 14-year-old girl. بيجيلها recurrent redness photophobia وماشيه على topical systemic steroids responds well. وعندها anterior uveitis، بس لما when we dilate the patient we find that there are vitreous cells, which is the picture on the right. And then we will proceed further. Once we start vitritis or proceed with the investigations, we find that there is something around the disc. There is disc edema, there are snowballs inferiorly, and on the fluorescein there is peripheral retinal vascular leakage, and there is neurosensory detachment. And then when we proceed with the investigations, and we will see how we proceed, we find that she has higher lymphadenopathy, allergy on the tuberculin skin test, and we discover that this patient is actually a sarcoid intermediate uveitis patient. Case number 2 is for a 36-year-old female which has left blurry vision for 3 years. It's also misdiagnosed as chronic anterior uveitis. But once we dilate, we find that the vitreous is not clear, it's turbid. So she has a granulomatous anterior chamber inflammation plus vitritis. When we dilate her, we find that there is actually pericapillary vascular sheathing, and on the periphery, and usually the inferior periphery, we find that there is a whitish dome-shaped elevation, and on the fluorescein, we find the peripheral retinal vascular leakage, and we have something that's very characteristic and common here in this subset of patients, which is an ERN. And then when we perform the tuberculin skin test, we find that it's actually highly positive, and she did have an old focus in the apex of the lung, and this confirmed the presence of a tuberculous intermediate uveitis. Case number 3 is for an 18-year-old female that has recurrent attacks of redness and photophobia, and she's complaining of scattered arthralgias, and she's been misdiagnosed as chronic anterior uveitis, but she had no sacroiliitis. When we examine the patient, we find that she has actually inferior posterior synechiae, which are pinpoint and sometimes broad, and we find that she has very minimal vitritis, and the retina clinically appears to be free. But when we perform a fluorescein angiography, we find very, very subtle peripheral retinal vascular leakage with a normal OCT. And then after we do all of the workup, including an MRI brain with contrast, because this is a female in the childbearing period, we find that we can easily diagnose this patient as the idiopathic form of intermediate uveitis, which is very, very common, and this is called pars planitis. So what is intermediate uveitis? It is a form of uveitis in which the main site of inflammation is the vitreous cavity and the ciliary body. So how do we diagnose vitritis? We have to dilate the patient well, and then I use my slit lamp, and I see the anterior vitreous face, which is behind the lens. And you tend to notice that there are cells in the vitreous cavity. The vitreous has 2 components. It has a liquid component, which appears as if it's empty, and it has the fibrillary strands. You have to notice where the cells are. Is it in the liquid phase, or is it just in the solid strands, and does it move with the vitreous or not? This is a way to diagnose vitritis, and this is a way to diagnose active and inactive vitritis. With treatment, these cells, they can become pigmented, and they can decrease in number, but they sometimes, in some cases, they can persist. So do not confuse these with cases of active vitritis. The second most important point is that cases of severe anterior uveitis can have an anterior spillover in the anterior vitreous space. So I use my slit lamp and I proceed backwards. I want to see the extent of the cell's distribution. Is it towards the mid-vitreous cavity, or is it even extending beyond that? This is a nice way to tell you if this is just anterior spillover or this is an actual diffuse vitritis. Another clue that can help is that if there is a good fundus view and we perform an OCT, you can actually see that there are cells in front of the macula, and this is a nice sign that this is actually vitritis and not just an anterior spillover. In some of the cases, it helps that when the patient looks downwards, we see that there are small grayish, white, or yellowish condensations that's present in the vitreous cavity in front of the retina, and sometimes when they are very, very severe, they can appear retrolaterally. And these are called snowballs. In even more severe and chronic cases, these condensations, when they are present in front of the very, very peripheral retina and the ciliary body, this is called snowbanking, the pars plana accidents. Always look inferiorly in order to see these things, and in some cases they are present with cases of retinal vasculitis, which can be seen clinically as sheathing, and they can appear in the fluorescein. They're usually peripheral and more inferior, but they can extend to the posterior pole, indicating that it's a more severe disease. So strict intermediate uveitis, we do not have retinal or choroidal nodules or lesions. But moderate to severe cases, they can have macular edema, and they can have a hot disc sign or a disc edema. We are still talking about an intermediate uveitis. Any form of severe uveitis can have macular edema or a disc edema, which can show a hot disc sign on fluorescein. This is not a panuveitis. The cases of intermediate uveitis, we have a very, very wide spectrum. They can be very mild, and I have some cases in which I discover pars planitis accidentally. The patient has never complained, and there are no complications. We have very minimal AC inflammation, few KPs, very minimal few vitreous cells, and they have very little sheathing in the periphery of the retina. We do not treat. On the other hand, if we have a case of severe and chronic intermediate uveitis, during when I first started seeing the cases, I haven't seen all of these complications, but now I've seen every single complication now. And the most common cause for diminution of vision in these patients is cystoid macular edema. They very frequently get an ERM. We've seen cases with very severe inflammation, in which the inflammation and not the ischemia tends to release VEGF, and these patients will have NVDs. And if they have severe peripheral ischemia, they can develop ischemic NVDs. And these cases, in some cases, have vitreous hemorrhage, and the chronic inflammation in the periphery of the retina can actually predispose to schisis and localized retinal detachment. So, what is the etiology of intermediate uveitis? I like to diagnose them into two main categories: infectious and non-infectious. In the infectious, we have to keep in mind certain things, the things that are common that we see. TB, endophthalmitis. I have an asterisk on toxoplasmosis and toxocariasis because I'll talk about them now. The posterior anterior chamber granuloma that the doctor presented in the presentation in the morning, in which the granuloma comes in the ciliary body, and viral, because some of the cases of anterior viral uveitis can have vitritis with it, and syphilis, we have to keep it in mind because we're seeing it increasingly common. And what about the non-infectious causes? We see a lot of sarcoidosis. Behçet's disease, they can come without retinitis, so they can present a form of non-granulomatous intermediate uveitis. Seronegative scar, as Dr. Therese said, they can come with intermediate uveitis. Fuchs uveitis is considered a form of intermediate uveitis. MS, tenu, and post-streptococcal. But we have to keep in mind three certain entities. Number one, we have to exclude the masquerade of an intraocular lymphoma, the presence of an intraocular foreign body, and finally, the idiopathic form, which is pars planitis. So how do I approach a case of intermediate uveitis? When I see a case of young age and is bilateral and usually asymmetrical, I tend to think of pars planitis, GIA, as Dr. Therese said, because we see lots of intermediate uveitis GIA cases and not just anterior, post-streptococcal, TIM. And in all of these cases, it can be granulomatous or not. How do we determine the case if it's granulomatous or not? From the KPs from the anterior chamber. Number two, if I have a severe granulomatous AC reaction and we tend to find extensive snowballs and extensive peripheral uveitis, I always think of TB, sarcoid, MS, or even sometimes severe idiopathic cases. If I have males, adolescents, adults, and they have systemic disease in the form of orogenital ulcers, the skin manifestations, arthralgias, recurrent DVT, I think of Behçet's disease even in the absence of retinitis. And finally, we also ask about the extramarital or abnormal sexual behaviors and the history of travel for cases of syphilis and Lyme disease. But I haven't seen Lyme disease here in Egypt. What do we encounter in real life? Usually, you are met with a case in which there is vitritis and there is something white in the periphery. And you have absolutely no idea, what is this white thing? If you have granulomatous KPs in the anterior chamber, and you might be lucky to have a high IOP, and you find that the vitritis is not very dense, try to determine the location of this white periphery. If this is actually a granuloma that's present between the retina and the vitreous, this might actually be a case of toxocariasis. If you find that the actual granuloma is within the retina and in the periphery, can be in the periphery, then this might actually be a case of toxoplasmosis. So toxoplasmosis and toxocariasis, even though it's actually some sort of a pan-uveitis, it can confuse us with intermediate uveitis. And toxocariasis, it's very characteristic that the granuloma, there is a fibrous band that arises from it, and it proceeds towards the disc and the posterior pole, and it causes an epiretinal membrane and fractional retinal detachment. The second thing that can confuse us is patients that are presenting with hypopion, dense vitritis, and you see lots of whitish granulomas or lesions in the posterior pole or in the inferior periphery, and these are actually bacterial or fungal colonies. And this is a case of endophthalmitis, whether it's endogenous or exogenous, and please ask about uncontrolled diabetes in these cases. And the third thing is that sometimes we're also met with this. You have to determine the level of the lesion of this whitish area. Is this something also it just snowballs or snowbanking, or is it actually something in the retina? And if you're lucky enough to have a few, try to perform an OCT, as the doctor said, to determine the level in order to see that this is actually a case of retinitis. So this might actually be a case of viral or syphilitic pan-uveitis and not intermediate uveitis. Anterior chamber granuloma, the presumed rheumatoid granuloma, is not always anterior. So the classic teaching that we used to teach 5 or 7 years ago is the adolescents, unilateral, a 9-year-old, unilateral presentation, recurrent redness, canal water contact. Now we're seeing completely different presentations in which the presence of the granuloma is present in the ciliary body or even in the peripheral retina and it's extending posterior. And the UBM here is the golden rule for diagnosis, as the doctor said. This was a case for a 9-year-old female, canal water contact, had unilateral severe reaction, healed anterior chamber granuloma anteriorly, and this was a nice clue, and she had persistent vitritis and tractional retinal detachment. Please do not forget the big masquerade, which is the intraocular lymphoma. Usually my clues for the diagnosis of an intraocular lymphoma is that old age, the patient usually doesn't complain of a severe red eye, the eyes are usually quiet or very occasional redness. You find that the cells circulating in the anterior chamber and the cells in the vitreous are actually quite larger than the cells that you see in the idiopathic forms. And you can see, might be lucky enough in the vitreous to find that there are very small and regular snowballs present everywhere. And they can have peripheral retinal vasculitis. And please be aware that these patients usually in very rare cases, they do not have macular edema. And the key for diagnosing these cases, of course, is with repeated vitreous sampling. So the management, as the doctor said, the worst thing you can do to a uveitis patient is to miss an infection or misdiagnose a masquerade. So the workup is according to history and clinical suspicion. We do not ask for all investigations for all cases. This is wrong. So what about the ocular workup? First of all, I perform fluorescein and OCT for all patients, and we do it bilateral even if the case is unilateral, in order to see the peripheral retinal vasculitis and the leakage and to see if the leakage is extending to the posterior pole. Second thing that I do perform is the UBM in cases of an suspected intraocular foreign body, and I do it for all cases of dermatode inflammation, the anterior chamber granuloma, to exclude the presence of an associated ciliary body in the back. Regarding sampling, the AC-TAP PCR, I'm a very huge fan for the AC-TAP, and now we have available PCR for viral, toxoplasmosis, and fungal. This is very useful in cases when you have very dense vitritis and you cannot have a view of the posterior fundus, and you're suspecting the presence of something white or fuzzy in the back. And then finally, of course, with the diagnostic sampling, the vitreoretinal lymphoma, and we take it with a undiluted core biopsy, and I think this will be good. So the sampling or the biopsy, it's not difficult. The AC-TAP, it can be done as an outpatient procedure, but I perform it in the ER. And in the vitreous biopsy, it's very easy. You can take it with a syringe or with the cutter. And as we said, we have the PCR for the infectious diseases, and you have to be prepared in case for the cytology, because this is a completely different preparation. This is the appearance of the results for the PCR, and it comes out in exactly less than 2 hours after you deliver the sample. And the kits that we use, that I use, are for the Children's Hospital. I have no financial interest, and they do the things that actually are common for opportunistic infections for the children who are on chemotherapy. So you will find that there are some bacteria and the herpetic viruses, but not all. There is no Epstein-Barr virus, and there is no rubella PCR. So the blood work and the systemic imaging to diagnose are used usually to diagnose the infectious causes such as the tuberculin skin test and the quantiferon. And I do run syphilis testing for all of my patients now. And virology, serology, it's a good negative test if it's negative. And I run chest imaging for almost everyone. Regarding the systemic imaging, I run for sarcoidosis if I suspect, if I see something granulomatous, the beta-2 microglobulin in urine for the TINO, the hepatitis markers, because if I'm going to start any systemic steroids, and usually in patients with bilateral females and which have intermediate uveitis and I see significant peripheral uveitis, I usually order a brain MRI to rule out MS, especially if I'm going to use TNF-alpha inhibitors. And we send to the rheumatologist. I just want to say that intermediate uveitis is a form of activity of multiple sclerosis. During the past 5 years, we were having great difficulty in dealing with the neurologist in order to convince them that MS equals more than optic neuritis. That some patients can actually have manifestations in the form of granulomatous intermediate uveitis with very extensive peripheral retinal vasculitis in the form of peripheral uveitis as a form of active disease. And I have been sending them patients and they do have MRI lesions, but they weren't convinced. Until during the past year, I've been receiving patients who have been already diagnosed with MS and having visual complaints. And one of them actually had the extent of a vitreous hemorrhage from severe peripheral retinal vasculitis and had NVEs. And now they're starting to become convinced. And I think it's underdiagnosed. So the treatment, of course, treatment of the cause infectious. Bear in mind that sometimes we tend to use systemic steroids under the cover of antimicrobials. Non-infectious, I think Dr. Muhammad will cover this, the steroid and the immunomodulatory therapy, chemotherapy, or surgery. And beware that intermediate uveitis usually requires some sort of a surgical treatment in addition. For example, the cystoid macular edema, intravitreal injections of something like Zurdex, the NVEs and NVDs, if not inflammatory and ischemic, we can augment with laser, and the ERMs, they need vitrectomy. And so the uveitis is not just a medical treatment. The picture on the right is for actually a severe body granuloma, and we treat this in our practice with vitrectomy. And the patient on the, this was on the left. The patient on the right, this is a case of severe peripheral ischemia from the intermediate uveitis. So we met with a case with dense vitritis. First of all, it depends on the type of patient and systemic history. Is it unilateral or bilateral? Is it asymmetrical? Any clues in the FOG? Peripheral granuloma, retinal necrosis, subretinal infiltrates. Is it granulomatous or non-granulomatous? And this is my main clue. The availability, always use the availability of aqueous or vitreous sampling and use the investigations ocular and systemic. Always keep a very high index of suspicion for infectious and vasculitis. Start the appropriate antimicrobials and steroids, empirical therapy. And as the vitreous clears, you can modify your treatment accordingly, but do not harm the patient. So my take-home message is, any case with anterior segment inflammation, please dilate the patient well and search for vitritis, because intermediate uveitis, in my opinion, is as common as anterior uveitis. And beware that sometimes vitritis might take time to develop. In cases of acute parsonamitis, they come in the first presentation with bilateral acute non-granulomatous anterior chamber inflammation, and then 1 week later, I find that they develop the vitritis. Please differentiate between anterior spillover versus actual highlitis or cyclitis. Meticulous examination, you might be lucky enough to find snowballs or snowbanking and peripheral retinal vasculitis. The clinical sense is super important. In cases of dense vitritis, always use the sampling in which you take an AC tap or a vitreous biopsy. Always exhaustive investigations, and watch out for MS in females with peripheral uveitis. And even if they don't have it, I usually order the MRI brain before I start the TNF-alpha inhibitors because they can induce MS. Early proper treatment to guarantee the best prognosis. Thank you very much.